Before we start this, can we just do, I think there's only a couple people in this room. Can we just, announce ourselves and who we are? Do you think that's okay, PHS?
Yes, that would be fine. Mark, you want to go first?
Absolutely. Good morning, everyone. Mark Natali. I am the State Network Director for New York for Unite Us.
Great.
Scott?
Hi, everybody. I recognize a few faces on here. Nice to see you again. Scott Cleary. I'm the founder and chief servant of SMC Partners. We're a healthcare technology and consulting company, but we are owned by Health First as of 2 years ago. And we're working with Health First as a customer, really. We're arm's length, building a digital platform that's going to connect them and hopefully other payers with clinical folks and CBOs doing human services work in the community. So that's the big idea, and I'm thrilled to be here with you this morning.
Catherine?
Sure, thanks. Hi, everyone. My name is Catherine Lucia. I'm a strategic initiative specialist with the New York eHealth Collaborative, or NICE. We work together in a public-private partnership with the New York State Department of Health to lead the statewide health information network of New York, or the SHINY.
Great. I think it's Jaffer and then Swetha.
Yeah, hi everyone. My name is Shweta Tanjore and I'm a project coordinator at Public Health Solutions.
And I'm Lauren Feldman. Hey, I'm also with Public Health Solutions in the IT department. Go ahead, Tavia.
I think that just leaves me. My name is Tavia Rauch. I am the Senior Director of Strategy and Clinical Informatics for the New York eHealth Collaborative. We've got 6 different HIEs operating in the state, and we're really trying to help interoperability and connect people to care and the data that's going to help make them successful as we transition into many different phases that we're all looking at over the next couple of months. All right, so we have some questions that PHS has provided. A lot of them are based off of the some of the background that we've had from the previous symposiums. So do we want to go through all of the key action steps? I know we're a little short on time. Do we want to go over those, PHS, or do we want to stick maybe to some of the more technology focused key action steps?
We could focus more on, maybe we could start with the technology one and then circle back to the other questions. How does that sound?
I think that sounds great. And I like the group here today. I think that that's a pretty good representation of, some of the larger stakeholders in New York State when it comes to data right now. So there is, I think it's safe to say that there's a consensus around the standardization of effective data sharing and interoperability, because we need to make sure that we're supporting an effective community resource network. So I would ask, what can your sector do to specifically minimize the potential access barriers created by the proprietary nature of the technology ecosystem? So what does that mean? So to me, that means, what can we all do to make sure that we are setting ourselves up and our customers up and our participants to make sure that we can move this data around the technology ecosystem, especially in New York State. At NICE, I would just say that what we would do to make sure that we're creating an ecosystem that supports interoperability and data exchange is that with any of the HIEs that we work with any of the projects that we do, any of the innovation, we'd make sure that we're using standards. If we use standards for data, then that means that the next person that we want to communicate with our technology can receive that data because they understand what that standard is. That's their data dictionary. That's their roadmap to understanding what our data is. And if we use a standard, we can move it from system to system. Well, what can the people here do? What can the people in this group commit to, and what can they talk about that would make sure that they're employing standards and that they're using policy to help information exchange.
Maybe I'll jump in. Could not agree with you more. It's all about standards. You know, as Health First invests in us to build this digital platform, it's going to be, you know, a hub, a way for people to connect. Not the only way, of course, but and we'd connect to Market Unite Us, and physician EHR systems, CBOs that have case management or care management systems out there. So it's all, for us, it's all about FHIR, the FHIR standards, and their Da Vinci and so on, all kinds of the Gravity project, leaning in and trying to adopt those standards where we possibly can, and then just be evangelists about it, saying you got to be able to talk FHIR. But CBO or hospital system or physician group out there, maybe you don't have an EHR that knows how to talk FHIR yet. Well, can you maybe we can meet you where you are and still handle SFTP spreadsheets or whatnot. I mean, we want to move the whole industry to FHIR with headless APIs and all that stuff, but it's going to take a long time. And meanwhile, I think there are things we can do to connect folks and meet them where they are. I have a whole point of view about where's the money to support all this, but maybe that's the next discussion.
Yeah, so I think you hit on some really great things. Yes, we need to use standards, and you referenced a lot of them. HL7, the Gravity project. I'd like to throw out maybe the AIRS taxonomy. There's a lot of different things that we could adopt and we could promote to make our data interoperable. But what also you said that really is important is that not everybody is ready for it. We love to say FHIR, it's easy, but that might be a little ways off. That might not be tomorrow. That might not be next year. And for some organizations, they might not even have any technology, let alone FHIR technology. So what do you think about the concept of, creating minimum viable data sets for the information we want to exchange? Because that could be something that we as a collaborative make sure to get behind, because if we can't focus on the technology, but we can commit to exchanging data that's relevant and the same sets of data, I think that also propels us forward. What do you think about that, Scott?
I think it's a great idea. Yeah.
Yeah. So
for those of you, this is Jaffer, I think I was able to join. Are you folks familiar that the Gravity project has actually done exactly that, and US CDI and US Core are working on the minimum data set for social care data exchange right now? So US CDI, the national standard, of course, for what is federally regulated, at least in healthcare, if not in other spaces, added 4 new data elements to the US CDI data set. And the team at US Core, which is the 5 employees that are contracted by the federal government, are now responsible for turning those 4 data elements into the HL7 specifications that now are going to be regulated probably in a year or two to be used. And that's the minimum data set. Now, Gravity has gone beyond that and has decided to create data sets that they just released maybe a month and a half ago that's available for everyone to review now. But there's really 2. There's US CDI 4 core data elements, and then there's what Gravity is releasing even beyond that. And so Gravity is always going to try to stay ahead of what the interoperability requirements are.
I think US CDI also just released a new version, right? About 2 days ago, correct? They have some new recommendations out. They have version 3 out. I think that's open for comment period, which is always important that, all of the stakeholders get in and submit their comments, because, together, I think that we can advocate for some change there. And, the Gravity project, I'm glad that you brought that up, because that is a standard that I think that we should all be referencing whenever we can. I know it's, we can't always adhere to everything because of technology limitations, maybe of our partners, but anytime that we can, we should be. I think, Mark, you were going to say something a little earlier when we were talking about adopting standards and maybe, creating minimum viable data sets.
Yeah, I was gonna agree. I mean, we're right there with the Gravity Project. You know, Scott, you know, we've talked about some of these things as well. You know, it's really important to have that type of common language. You know, we absolutely agree. You can't have apples, oranges, hot tubs, and lawnmowers and try to expect anything to really happen, right? So, you know, we're really right at the forefront. Smart on Fire absolutely invest a ton in there, even going as far as bi-directional in a couple months. So, but to your point, you know, there's a lot of organizations that are absolutely not down that road yet. So we have to make sure that we're accounting for all of those scenarios. And that's where we really have that stepped approach to be able to interoperate as effectively as possible, especially when we talk about what this is going to look like in the coming year or so with the 1115 waiver and the ability to have those common data sets, that common outlook to be able to in real time say, how are things going, right? So, you know, we always say we don't want to be able to have to wait 6 years to look back and say, is this a success or not? We want to be able in real time to have that common knowledge, that common data to be able to look at and evaluate the direction of how the state is going. And everybody needs to be able to look at that same type of information in the same type of manner. So, you know, we're heavily invested in partners in the Gravity Project, and, you know, all of our engineering team coming around every single customer and partner that we have saying, you know, what does this look like for you? Where are you at? And how do we meet those abilities now and help with the future of that specific organization?
I think that this is a good time to, I do want to take some time to get to some maybe the funding questions that Scott said that he wants to discuss in this group, and I think that's important. But we're talking about moving data around. We're talking about meeting our customers where they are technology, that we can't just say it has to be fire. We want to get to that. We want to get to all the standards in Gravity. We want to make sure that we're exchanging the minimum viable data set. But can we talk maybe a little bit now about how that data is moving around? Because, you know, I think that there is a closed loop. There's a small closed loop that is within a system when you're looking at maybe a referral or a piece of data or an assessment, you know, having its full life cycle in your system. But I think it's important to maybe to talk about how we're targeting others in that larger closed loop. So are we partnering with the right people to make sure that data is getting back to the providers and make sure that data is really moving around the technology ecosystem so we're getting it the right way? So if we have the pieces to make sure it's moving, are we targeting the right people to make sure it gets where it needs to go to improve that patient outcome? I don't know, Mark, you were just talking about, you know, how dedicated you are to standards. Maybe what are you doing at Unitas to make sure that you're partnering with the provider organizations and the right people to close that loop on maybe the referral or the assessment?
So as far as just the referrals in the closed loop, you know, our technology and our platform is really that's the basis of it, right? I mean, it really is creating that true coordinated care and the insight across anybody who touches that individual and is part of that care team. The data, the information shared back is able to be looked at. We have you know, everything from what we call CBO Insights, which is our Tableau dashboards that you can slice and dice and do everything. We have health equity dashboards. We have everything to be able to say, what are we as an organization, as a CBO from this standpoint? Who are we serving? Where are we serving them? How efficiently are we serving? What does our client ecosystem look like, right? So, and then we also have obviously SFTP files. We have all of those things because we also have organizations that are able to really ingest data and work with it in the way that they need to, and especially large volume providers who have data warehousing capabilities and all that. So we make sure that we're accounting for that as well, and really going across the spectrum of how data needs to be utilized for strategic information and direction for the organization itself with its leaders, as well as just taking a look at the entire network and space and saying, okay, how do we get to predictive analytics, right? So we do that as well. So we, recently acquired Carrot Health, which is really next level data information, and really has information on 300 million people in down to the individual level, and really taking a look at what are the needs across 500 different types of realms when it comes to what makes up an individual, and be able to look at actually individuals in neighborhood levels and say, what is the needs here? And then start predicting what those needs are. Do we have the right organizations on that closed loop referral system? How do we really get ahead of it instead of being reactive? So we're really looking at what the future of that looks like and how we can utilize data to create a more robust community of how those needs have to transpire, as well as not just what the needs are, co-occurring needs, reoccurring needs, all of that, to really inform what care needs to be in each community. So from a closed loop system, which was your first part of your question that I'm taking a little long here, it really goes beyond just what's happening in that closed loop system, but what is happening around it and has to inform it and what all of that data means. And again, it's really important that, our organizations own their data, and we help facilitate how that data gets to them, as well as how it's utilized, and we're partners in that all the way.
No, I think that's great. Everyone's healthcare continuum looks different. It sounds like you're defining all of the pieces of data that make up that person's healthcare continuum, and all of that data is going to be different, and you need to be proactive versus reactive. And I think that that's great. I think you hit all of the pieces there. I think someone else was just about to hop in.
Yeah, I want to speak up.
Sure.
I think the question that you're hitting on it goes far beyond kind of the, and Mark, don't take this the wrong way, kind of the marketing slick of features and functionality that a lot of our systems can handle. The bigger question is appropriate access to data across different systems of record. And I think the challenge that you shared in the beginning of our discussion is that some nonprofits are going to use SMC, some nonprofits are going to use Salesforce, some nonprofits are going to use Healthy Planet, some nonprofits have an access database, other nonprofits are going to be logging into Healthix and Shiny system. Some are going to be regulated because they're in behavioral health. Others are not going to be regulated and going to be a mom and pop shop. And at the end of the day, the beginning of the conversation was, we are not going to expect all of them to be paying for and implementing a FHIR-based technology. Now, the ONC may require a FHIR-based technology if you want to participate in an 1115 waiver, because they have to have some mechanism for standardizing the data exchange, as well as fraud and abuse and auditing and tracking, and that's all understandable. But at the end of the day, there's a lot of programs in the state and in the city, more than 15,000 at my last count, that are serving people. And if we make them all available through a true health equity approach, what will allow a small mom and pop organization to see and share data with a large organization like Mount Sinai, for example, and do so across industry, meaning healthcare is regulated, but the food pantry may not be. And so when is it appropriate and how is it appropriate to get access to that information? I think that's the root of so much of what we're trying to solve for in this question. And I think the concept of allowing choice for the organizations, meaning choose the system that aligns with your mission, with your reporting, with your analytics, with the work that you're intending to do, is so critical. And we've seen in other states where there's a government mandate or a government, monopoly, so to speak, that says you have to use this if you want to participate in our thing, has struggled and failed, because you're really dictating to the nonprofit community at scale how they should do their work. And I think that's a big challenge we have to understand. I think the root of this issue, however, is privacy. It is permission-based access to the information. And so if Mount Sinai has a data sharing agreement with Healthix, and every social care referral they make, closed loop or not, that they want to send to the HIE, so that behavioral health nonprofits can access it through the regulated HIE, that's wonderful. But that doesn't mean that the behavioral health organization has to use, a mandated, technology. And then there may be organizations like the food pantry who want access to that coordinated history that Mount Sinai is doing. But because they're not a part of that coordinated relationship, they shouldn't see everything that Mount Sinai did. They shouldn't see the mental health referral, or they shouldn't see the domestic violence referral, but they should see the food pantry referral and be able to request access to the other history and get permission from the individual. So there's a permission, and privacy notion. There's a interoperability, notion. And I think those are really key to this concept of coordinated care. And the vendors out in this space handle this very differently today. And I think that's really important.
Yeah, I think you make some really good points there. And I think some of that brings us back to that minimum viable data set, right? So maybe not everything should be floating around and being exchanged on the patient. Maybe there are some things that maybe aren't as relevant, but we at least have to start somewhere, right? We have to start exchanging data on a really interoperable global level throughout all of these systems, irrespective of technology. And I think that's what we're really all trying to figure out here. How are we going to partner? How are we going to use the technology to get data to the people that are doing the work to improve the outcomes? I think one of these questions that was, a different key action that we were talking about is, what are you guys going to do? What is your sector's current approach to engaging the different communities? So, how do you get the mom and pops? We're talking about the mom and pops that have the paper, no system. How do you get them to the table to use your technology, irrespective of what it is? How are we engaging these people to use whatever platforms make sense for them at the time, or your platforms? I think, Unite has talked a little bit about doing some analytics to understand, with that person, where are they going, what's happening in their community. Anyone else having any techniques that have been successful in engaging some of these maybe non-traditional healthcare agencies like a food pantry to use technology or adopt it?
Yeah, I'll just mention, so we have an entire community engagement team that works. I mean, when we talk about just the city itself, we have team members for each borough and beyond. So they're really, and they live in that area, so they know the community, and so they work with every organization in those areas. But even the mom and pops, I think your question is really a great one, because a lot of times there's small staffs, they're doing 46 different things in each of their roles, and it's hard to adopt new technology. So really each of our community engagement managers really work one-on-one with understanding how that organization operates. What are all the roles in the organization? How do they, perform the whole continuum of how they care for a client's needs and how they interact across their community, who they interact with, and really start mapping out workflows with them of what it could look like and what are the opportunities where technology can actually save them administrative time. And looking at the benefits of what that looks like, looking at the negatives of what that might be as well. So really just having that individual conversation and developing that relationship and walking them through how all of that works. Everything from training, one-on-one training needs to what have you. So really addressing, and we call it's change management, right? So all of our team members are really trained as change managers, because that's what it's about, especially when you talk about smaller organizations in the corner food pantry. It's really bringing them along from what they've been doing and what they have access to what it could look like. And it's definitely a change process, and we know that takes time. So our team is all trained in that and works with them in every way to get them to whatever stage they need to get to next.
I like how you use the term change managers. In my world, technology, where we all come from, I think that change management means, a bunch of people sitting around a room looking at a spreadsheet saying, are we going to change that digit to look like something else? Are we going to enable a new drop down? Where's the new bucket? Everybody agree, when are we going to do it? And that's just kind of an arduous process that we have to manage in technology, right? We've got to manage our technology, we've got to drive it, we've got to do it responsibly. But I like how you talked about change managers as managing someone's perception of what they're doing or changing their behavior. So I think that was, I appreciate that. And I think that that's great. Another big motivator of change sometimes is money. Everybody's kind of bringing it up. Where are we going to get the money? Where's the funding going to come from?
Well, I think, you know,
talk about that.
I can jump in a little bit. You know, one of the reasons we are with Health First now is that I love their business model. You know, they, for, I don't know, 20 plus years, they've been true partners of the, you know, their hospital sponsors who are the board of Health First, and Health First serves at their pleasure. And if they are helpful in, you know, containing cost of care and helpful in delivering high quality care, and, you know, they get that capitated money from Medicaid or Medicare, and if there's money left over at the end of the day, that goes right back to the hospital. So there's real partnership there. And, you know, they've got 1.7, 1.8 million members, really, you know, a full risk model. So it's like, all right, if we believe, we Health First or we Mount Sinai or Maimonides or whoever, if we believe that investing in human services, social services, food pantries and beyond, that's going to actually make a difference in, you know, the health of our member and impact favorably the total cost of care, including that community stuff, we'll pay for it. Well, does pay for it mean here's access for free, provider, human services provider, to a system that you can use, and, you know, this and the system we will give you, and I don't know who we is, we got to figure this out, but the system you can have will be interoperable, you know, at least for Health First. And, you know, and that's our job as SMC. We've got all 1.8, 1.7, 1.8 million members loaded in our, you know, FHIR repository centrally. We've got claims, we've got benefits, we got all that stuff. All right, now, if you want to participate, community provider, you know, you got to agree to do some data sharing. And Joffrey's right. I mean, you know, the permissions and the consent is a big deal. But we'll, you know, create the pipes to enable that to happen. And then, okay, wait, Mount Sinai is in the chain, and all these other big hospital systems, integrated systems. Well, they're at risk too in the Health First model for sure, and beyond. And they and community providers want to assume, you know, more and more risk, I think, because there's an upside. Get out of the fee-for-service business over time. Hey, they'll invest in it. You know, they'll figure out who's important in their community, give them the technology, pull that in. That goes back to the plan too, hopefully, and, you know, hopefully multiple plans, health plans will plug into our platform. So I don't know, but I think the money, you know, paying for the social services and then saying the condition of taking the money is contributing data according to this standard, and we can help you do that. So that's a long speech too. I don't know.
No, that's good though, because you're talking about how you're working with an organization that's trying to use the dollars to invest in some of the needs of our population and trying to maybe use those dollars as a lever for data, right?
Yeah.
We don't have a lot of levers when it comes to exchanging data, and sometimes dollars make that work. What about?
Well, I just real quick, you know, we are pretty deep in Massachusetts with a lot of community-based organizations. And what Mass Health did, the Medicaid agency, they said, okay, listen, we are going to pay for flexible services, they call it, which right now is housing and nutrition related services, you know, but the condition is you accountable care organization there, I don't know, 15 or 20 of those that they've anointed in the state. If you're going to refer one of your members, you know, that's attributed to you to get flexible services with a community provider that offers those things, you got to fill out this form. It's called the VPR form. What the heck is that? Verification, planning, and referral. So what's the condition of the person, some demographics and some kind of clinical high level, you know, SDOH kinds of needs. And then what's the plan? for nutrition or housing services, and how are you going to do it, with whom? Send that form to us. Well, jeepers, send a form every time we got to do a referral like that? Give me some technology, says the CBO. So that's what we do. That's what Mark, that's what, so, okay, use some technology to produce that digitally and get that up to the state. And now you're in business and you've started to exchange data and collect data. And now who else might I share it with permission of the, of the customer, the client, the patient, the member. So I think that's a real model in the state of New York Medicaid department. I think that's where the innovation can come from. If they put a pile of money through the managed care organizations and say, this is for social services, I think that is kind of what's required, or would really be an accelerant in this whole thing. And then here's some more money for, qualified or selected technical assistance vendors, if you will, who can go out into the community and help people get hooked up with some technology. Not one mandated system, but systems that are interoperable, like Mark was saying.
And I think, when we look at the 1115 waiver, concept paper and all that, and we're talking about how does that support community-based organizations even at the smallest level, the infrastructure that it talks about with which I love, Zach, PHS, Community Resource Network versus Social Determinants of Health Network. I do like that. Zach and I talk about that all the time. So, really the lead entity there and having the ability to have dollars around, actually in this concept, about 8 billion that's going to flow through those organizations to really funnel down in a prepayment way. I think that was a really important part of it. So there's obviously value-based payments we're talking about and all of that, and dollars coming back after service is rendered, but in quality service, not just volume. So I think that's an important part of it. But I also think what's really important is the ability to get dollars in a prepayment way to community-based organizations, because I used to be the CFO of a large community-based organization in upstate, and a lot of it is you have to wait 2-3 months for your reimbursement, and so you're constantly using your line of credit, you're revolving and all that, and you can't really create great service in that way, right? So prepayment, I think, is a really, really important thing to have. Organizations have the ability to not worry about what that structure or infrastructure looks like, and especially prepayment in dollars, as Scott said, when it comes to technology infrastructure. So how do we really make organizations whole and give them all the tools and abilities that they need to do the great work that they do, and not be limited by staffing issues or capacity issues because they don't have the dollars that are there. So to Scott's point, just wanted to add that.
I like this. So this was one of our key action steps that, we didn't necessarily go step by step on the slide, but I think what we're reporting out is that, for diversified, flexible, sustainable funding in the city, what we want to do is we want to make sure to leverage we want to advocate as a collaborative for prepayment dollars when the 1115 waiver funds start getting dispersed, because that's going to make it a little bit more of a sustainable environment for our community-based organizations. And we want to partner with our managed care organizations whenever possible and use them as a lever to increase data contribution, because that's going to allow us to measure our performance and improve our outcomes. So I think we did a really good job on the key action step 1 here as a group for the report out. Pop over to key action step 2. All right, so an administrative background and infrastructure to support the CBOs at all levels. I think we talked about that too. Just to kind of recap, we talked about how we need to get out and we need to engage in the communities in which our services touch. So who can we work with? What are the touch points? What's the health part of the healthcare continuum for our most disadvantaged population? Who are they going to? What are their touch points? Are they food pantries? Are they clinics? Are they urgent cares? And Unitas, Mark really talked about, boots on the ground, community engagement, but engaging our change managers to talk and educate and being able to meet them wherever they are with their technology. Does anybody else want to talk a little bit about this key action step and maybe a little more pointed on how we would try to push policy or administration into this infrastructure that helps us all move our mission?
I'll say a few words. I think this is it's a bit of an open-ended question, just like you know, the other vendors. We have a shared service community engagement team and community engagement liaisons by all of our customers, including the 25, you know, in New York City, and they're all on the ground working together. And so I think in Massachusetts, you know, we drive forward that mass health work that Scott was just you know, mentioning, and where the system, where the services and the VPR form are actually filled out. But I think what we've learned is that when the private sector, including all of those organizations that are leveraging different networks, come together and realize that they're not competitors and that they're collaborators for the purposes of the CBOs, that's when their shared investments can really come to life. And so, for example, in California, where we work with, you know, HealthNet, we work with, you know, Centene, we work with Anthem, we work with LA Care, we work with, you know, almost all of the major MCOs, plus a lot of other health systems. They are competitors in their close regions. And they've decided to come together every quarter and have meetings together to discuss what levers they have to invest in the community. And so one organization says, hey, we've got a bunch of budget where we can provide laptops. Another says, hey, we've got 3 staff that we can use as community engagement liaisons to do webinars and education. We've got another customer that says, hey, we actually can provide funding for medically tailored meals. And when they put those all in the same pool, they're serving the CBOs from one lens, not from a competitive lens. And I think that that's an important component of a shared service model that our customers are even adopting. I think the administrative notion also of consent is interesting. There was a national call, with a national committee, and 2-in-1 San Diego was on the phone, and they were talking about their 100 partners in San Diego. And one of the executives on the call asked, you know, can any one of those CBOs look up my friend Joe and see that Joe has diabetes because of the one piece of paper that Joe signed in your network? And, you know, the 2-in-1 director said, well, yes, you can actually look up anybody and see their medical history because they signed that form. And there were gasps and gasps. And I think this goes to the question of the administration and the infrastructure of what is appropriate, you know, within the infrastructure that's created. And so to that point, what we've created nationwide is what's called coalitions. And these coalitions are organizations that can come together, including a state agency or a state entity, to say, we are going to share this minimum data set. And we're going to do it because we're collaborating for the purposes of the Mass Health, you know, waiver, the California CalAIM, you know, program, or any number of coordinated, you know, programs. So we do have to define, I think, the coalitions and the collaboration that's happening, and it can't just be an open lookup, you know, across an entire state. So I think the infrastructure can be in place, but then we have to define, you know, who is the coalition in many of these cases. So hopefully that's helpful.
No, that's great. And we're all talking about how diverse this is, how many people are involved, how much technology is here, how competitive this space is. If we have to have an administrator or someone that we trust, and who's that person that is going to own that consent, who are we all going to work with, who's going to be that convener or that collaborator of all of our work, recognizing that this is still a business for many people. Who are we going to turn to for that as a convener? Who's going to be that person? And I think that's, you know, that would be very good for our mission if we could come together and we could decide on a collaborator, or we could decide on a, you know, naming the collaboration and coming together with some sort of frequency to bring this mission forward. There's going to be a lot of people coming into that space, and, you know, being part of the collaboration is what I would encourage everyone to do. Just, there's going to be many of them, and participate and do your best, because it's going to make a big difference for all of us. I think that we've key action step 3. We're running on like 3 minutes. Let's just pop into 3. I think we covered everything, at least enough for a report out.
So I think we didn't quite, I don't think, hit on decision making, but I suppose if we have, you know, community-led planning groups, then as part of that community building process, some kind of governance structure would be important to develop and adhere to, so that you know, the role and the scope of various partners are clear.
Yeah, so again, finding that group to convene so that we all can make decisions, you know, collaborative decisions, the same decisions about interoperability, about data sharing, about privacy. If we all have different consent policies, the data is not going to go anywhere. It's that first gate right in the system. So coming up with the collaborator, the convener, and the process in which we can all work together, I think is really important. And I don't think we came to anything on that. I think we just talked about how important that's going to be as we move forward.
You know, I'm going to sound like a skunk at the picnic here a little bit. I don't know. You know, I spent 8 years as the for-hire executive director. So that's a misnomer because I was a consultant serving eHealth Connecticut. That's the 501c3 that was stood up, you know, 10 or whatever it is years ago to be the health information exchange in Connecticut. And we had Anthem and Aetna and Hartford Healthcare and Yale and ... and community people. We had the commissioner of DSS. We had the lieutenant governor. There you go. And we were going to do it for the state. And then here comes the money from ONC, 10 million bucks or whatever the thing was, going to DPH at the state. And DPH says, what's that eHealth Connecticut thing? That's a private sector baloney. We're going to take the money. And then they did their own thing. And frankly, it just did not work. We never came up with a business model. Why are we here? Then we got into the consent discussion, and half the board said we got to do a you know, a hard opt-in wet signature on a piece of paper, and others saying no, do like they did in Maine. It's opt out. You're all in unless you know, go online and opt out of the thing. Oh, that's never going to, and we never got it together. So I just am skeptical about putting, you know, that singular A in the prior slide. I don't know. And we're talking about New York City. I mean, Connecticut, it's only 3.5 million people. You would think we could get our act together, but we never did. So I you know, that's kind of a negative. But New York is way ahead of Connecticut. New York and Massachusetts, I think, way ahead of, you know, the fee-for-service mentality of DSS in Connecticut. I'm speaking out of school a little bit. So there's a chance, I think, but I don't know how to do it. My brain is too small, and I don't know enough people to know if this could actually work. That singular A, you know, A administrative, you know.
But maybe it's a data sharing policy that supports the mission. Maybe it's not a organization that's going to convene everybody and change the world, but maybe it's a collaborative that works on
Yeah, absolutely.
sort of data sharing policy that's going to support how we need to move forward. Because it's very difficult. If we don't have the gate, if the gate's not open, we can't push anything through it.
You know, I'll tell you how Hartford, Connecticut got developed way back in the day, and it's,
also,
you know,
just the time check, 3 minutes, I think.
It was a CEO of the Hartford and Aetna and one of the other big insurance companies that got together and say, okay, here's what we're going to do. And let's agree, you know, so we'll get our teams. And so I think some kind of a collaborative with leadership from the private sector, with participation, guidance from the public sector, that'd be great to agree on that minimum data set. Here's how it's going to go. And then, okay, where's the money? Medicaid, where's the money coming into the MCO? So I think that's a big idea and a really good one. Yeah, I don't know how to do that.
Scott, no, I think it's a great point. And, you know, we have the collaborative in Massachusetts of 30 organizations, and they all have different incentives. They all have different projects they're working on, but they all come together to make sure that they're approaching the community in the right way with the right message. And, you know, in Philadelphia, same thing, 30 organizations that meet, you know, every month, and they've decided on a brand and an approach, and they're even though they have different missions and different target populations, they're still approaching the community in the same way. So there's a way, I think, to have your flexibility in the private sector of focus, but also your singular message to the community.
Yeah, we had a lot of board members coming to those monthly meetings, frankly, looking for, competitive intelligence as opposed to leaving their hats at the door and coming in and acting on behalf of the community. But so with the right participants from the right players, public, private, that's the way to do it. I totally agree. If you can. Yeah.